on the right side of the lower leg. So it starts with the heel strike, and this is how it moves forward. Focus on the ankle only. So the gait cycles ends with the heel strike, or like the where the gait, that is also the end of the gait cycle. So ankle movement is initially there is a plantar flexion, followed by dorsiflexion. Then again there is a plantar flexion, and in the swing phase there is a dorsiflexion at the ankle. So if you look at the ankle moves from plantar to dorsi, dorsi to plantar, again to dorsi. So if we look at the kinematics graph, which we see in very routinely in our gait analysis report, the one with the red color is the stance phase. The one in a green is swing phase. The horizontal line or the x-axis is representing the time, and the upwards, that is a plus, is dorsiflexion, and the negative or the minus is plantar flexion. This is conventionally how we look at the ankle movement or describe the ankle movement in our gait analysis reports. So to begin with, ankle is in a neutral position at the beginning of the gait cycle. And then there is a small amount of plantar flexion, which is around 7 to 10 degree of plantar flexion. After that, there is a reversal of the movement, and there is a dorsiflexion, which reaches to the tune of 10 degree of dorsiflexion. After that, there is a sudden plantar flexion, which is more in magnitude, and that is a third part of the stance phase, followed by again a dorsiflexion, and then the ankle joint is in a neutral position. So if we look at this, mimics like the chair, a rocking chair, which moves from front to back to front to back. And a great person, Jacqueline Perry, the person who actually started describing the human gait in great detail. And I would recommend you to read her book, Gait Analysis, Normal and Pathological Function. Many of the concepts in this lecture are based from what she has described in this book. So now coming to the most important question, which muscles they control the ankle joint movement? This is where the understanding of the various muscles which are working at the ankle joint, which comes into play. So this is what the normal ankle graph. So we are focusing on the first part, that is the first plantar flexion which is taking place. So we understand, or we are trying to understand that how this plantar flexion is taking place. I consider this as a plane which is landing. It usually lands on the two rear wheel first, and after they come in the contact, there is a slight tilting of the front portion, and then all the three wheels are on the ground. The same thing with the human gait cycle. It begins with sorry, the heel coming in contact with the floor, and when it comes with the floor, the impact comes. The body weight strikes the floor, and we know that according to the Newton's law, there is an equal amount of impact, which we call it a ground reaction force. So this ground reaction force starts from the area, or from the point, from the heel, and it goes upwards towards the center of the body. At ankle, the black dot is suggesting the center of rotation of the ankle joint. Now this ground reaction force is behind the ankle joint. And if I ask you which movement it will carry out, it's very easy to understand. Because it is behind the ankle joint, it will carry out a plantar flexion. So this plantar flexion is caused by a ground reaction force. But we need a muscle which make it smooth. And to understand that, let us see this. So this plantar flexion is controlled by a tibialis anterior. And this tibialis anterior, I have shown it in a blue color because it's working eccentrically. It's allowing the slow plantar flexion to take place so that there is no slapping of the foot. In conditions where this tibialis anterior muscle is not working, there will be a rapid plantar flexion because the smoothness of the plantar flexion will be lost. So the first important point is tibialis anterior works eccentrically and cause slow plantar flexion, which is, we call it a first rocker. What will be the effect if tibialis anterior is weak? If it's weak, then these slow plantar flexion will be lost and there will be a rapid plantar flexion, and to which we call it a foot slapping the ground. Coming to the second rocker, here there is a dorsiflexion from the foot which is now in contact with the floor. There is a dorsiflexion like this. When I ask this question to undergraduate and the postgraduate students that how this dorsiflexion takes place, and most of them, they say that, but before that, let us understand that this is how the ankle moves in this particular position. This is how the dorsiflexion takes place, and the foot is on the ground and the tibia is moving forward. When asked questions like how this forward progression of the tibia takes place, a lot of people say that it's a tibialis anterior which is drawing it front, but actually it is not like that. The correct answer is the tibia moves forward because body is moving forward. To understand that, let's go back to the initial animations which we saw, like this. Because the upper body is moving forward, along with that, it takes the tibia to the dorsiflexion position. And at that particular point, the soleus muscles works from behind eccentrically and control this forward progression of the tibia. So the first rocker is by tibialis anterior eccentric work. The second rocker is by eccentric work of the soleus. So second rocker is controlled by eccentric contraction of soleus. Coming to the third rocker, in which we know that there is a rapid plantar flexion like this. And this takes place by a combination of two muscles, the two powerful muscles, gastroc and the soleus. They work together and they carry out rapid plantar flexion, and which provides energy to move forward. Quite an amount of energy is provided by these two group of muscles which work together to produce rapid plantar flexion, which gives us an energy to move forward, which we call it a push-off. Coming to the fourth rocker, or actually the fourth phase, in which there is a dorsiflexion, and this dorsiflexion takes place. The function of this dorsiflexion at the ankle is for the ground clearance. And at that point, the tibialis anterior works concentrically. So it has been shown in a green color. And as shown over here, you can see that there is hardly a centimeter distance between the foot and the floor. And this dorsiflexion is very important because if this is not carried out, then there will be a problem with the ground clearance. So ankle dorsiflexion in the swing phase allows ground clearance. Coming to the last part, there is a few degree of dorsiflexion to which it comes to a neutral position from where the gait cycle is going to start again. And this is again by eccentric work of the tibialis anterior, which is going to continue in the first rocker or the beginning of the gait cycle. So now we are trying to revise what we understood, that this first part, plantar flexion, is controlled by eccentric work of the tibialis anterior. Then the dorsiflexion is controlled by eccentric work of the soleus. This rapid plantar flexion is controlled by both gastroc and soleus working concentrically. So it's shown in a green color. And then there is a dorsiflexion, which is controlled by tibialis anterior. Now it's working concentrically. And in the last phase, the tibialis anterior is working eccentrically, which is going to continue again in the first part of the gait cycle. So that was about how various muscles, they control the ankle. So I would just like to break at this particular point for have some thinking. If we want to draw the kinematics of this boy who is walking with this type of gait, how will be the ankle graph of this boy? I'm thankful to Dr. Gopakumar for sharing this video with me, and it was recorded, or the gait analysis was carried out at Jayanth's gait laboratory at Bimra. So if we try to see that in the first rocker, in the second rocker, in the third rocker, ankle remains all throughout in the dorsiflexion. And if we look at both the ankles, they are remaining in the dorsiflexion all throughout the gait cycle. There is a up and down, but it's more towards the dorsiflexion side. Okay, so now we come to the second part of the topic, that is how knee movement is controlled. Again, I just request you to observe how does knee moves. We are looking on the right side of the limb, and I want you to focus on the knee, how it's moving during this gait cycle. So rather wasting much time in asking you, again, if we look at the kinematic graph of the ankle, again, the red one is the stance phase, the green is the swing phase, the horizontal line is the timeline starting off the beginning of the gait cycle and end of the gait cycle. Again, the horizontal line is at 0 degree. On the y-axis, the upward part shows the flexion at the knee, and the lower part shows the extension. And if we draw the graph, more or less, it is like this. Just a word of clarity that I'm showing as a one line. But if we really want to describe, then we need to have a 2 standard deviation. But to make the things simple, to make the things easy, I'm showing it only with one line. So the knee movements during the gait cycle have a 2 bump. The one is a small flexion in the stance phase, initial stance phase, and then a bigger knee flexion in the later part of the gait cycle, particularly during the swing phase. So now, again, the same question, which muscles control the knee movement during the gait cycle? Like we did it for the ankle, we are doing it for the knee. It starts with the neutral position. From that, there is some element of flexion. That's a small degree of flexion, again 7 to 10 degree of flexion. And let us understand how that flexion takes place. We saw this, that at the end of the gait cycle, this is how the limb comes and touch the floor. The ground reaction force is generated and it goes towards the center of the body. The black dot shows the center of the knee joint. And ground reaction force is behind the center of the knee joint. So it will produce flexion at the knee joint. So the flexion, initial flexion is produced by ground reaction force. But the quadriceps works eccentrically and it slows down this knee flexion and it dampens the impact which is coming. So at the ankle, it was tibialis anterior. At knee, it is quadriceps working eccentrically in this part of the gait cycle. Now, we are trying to understand, and the most important thing which we need to understand when we are dealing with the child with a cerebral palsy, the initial extension which is taking place during the stance phase or in the mid stance phase. And most of the gait abnormality, particularly the crouch, is because of the problem which are taking place during this part of the gait cycle. So let us understand that how this extension takes place and what are the factors which jeopardize the extension which is taking place in this part of the gait cycle. So we are going to understand that, and this extension is caused by a two group of muscles, which is called a plantar flexors knee extensors couple. Many of you must be knowing what is force couple, but for those who are hearing this word for the first time, what is force couple? Let's see, like you are driving a car and you have hold a steering wheel with one hand, and this one hand will try to rotate the steering wheel either clockwise or anti-clockwise. So force is coming only from one side. On the other end, if you are holding the steering wheel with two hands, in that case, both the hands, they can work together and they can produce the movement clockwise or anti-clockwise. And when two forces are working on either side of the hinge, this is called a force couple. The same thing works at the knee joint, and we will understand that how and which are the muscles which are working together to produce the force couple. So the two group of muscles, the first is the knee extensors, and second is the plantar flexors, which is working from the other side of the knee joint. So which muscles work when? The initial part of the extension is taken care by the quadriceps, and the later part is controlled by the soleus. Let us understand the mechanism which is working at this particular point. So here quadriceps is working concentrically and it produces the active extension. The more important thing is the later mechanism, which is called the plantar flexors producing the knee extension, which is sometimes difficult for person to understand, like how soleus is working as a knee extensors. So this is where the foot is in contact with the ground. The force is coming from below. Soleus is now trying to lock the ankle joint like this. Now try to understand this force is in front of the knee joint, and because of that force, it will try to produce the knee extension. Above the knee joint, it was quadriceps. Below the knee joint, it's the ground reaction force and the soleus. They are working together and they are producing the knee extension. Coming to the third part, where there is a, it is at this particular point where the body is in a neutral position or the knee is in a neutral position. And we need to understand that body has a very unique mechanism to maintain the knee without help of any muscles. So here the ground reaction force is going in front of the knee joint, and by that the knee is kept in a straight position or in a neutral position. But the more important thing is, like, it is the capsule which is preventing the knee hyperextension and which is locking the knee joint. So ground reaction force from the front and the capsule from behind, and it keeps the knee in a neutral position without help of any muscle. So knee remains extended by ground reaction force, soleus, and the capsule. Now, what happens, like when person develops the fixed flexion deformity at the knee joint, there is a significant deviation in this phase of the gait cycle. To understand that, I am going to show you the three type of knee flexion, 3 degrees of the flexion. The first is in a 0-degree knee flexion, the second with 20-degree knee flexion, and the last is 40-degree knee flexion. So when the knee is straight, the ground reaction force and the capsule, they are able to keep the knee straight in a neutral position without help of any muscles. With the knee flexion, now the major shift which has taken place is the ground reaction force has now moved behind the center of the knee joint. And so instead of knee extension, now it is producing knee flexion. And if this person wants to remain upright, then a quadricep has to work. Then and then it will be able to maintain the flexion component of the ground reaction force. As the knee flexion increase, the ground reaction force moves away from the center of knee joint. Because of that, there is a increase in the distance of a ground reaction force and the center of the knee joint, and that produces more flexion moment. And to overcome that, the quadricep has to work more. So as the knee remains in a flexed position during this particular phase, the quadricep has to work more and more. To show this point, look at the quadricep muscles of this particular boy. They are really working very, very strongly to produce the knee or to maintain the knee in an upright posture. Now coming to the fourth point, where there is a rapid flexion at the knee, which is called an acceleration phase. And it is the short head of the biceps is working at this point. A lot of people, they believe that it's a hamstrings, all the hamstrings, semimembranosus, tendinosus, and the biceps, they should be working. But actually they are not working because the reason is, if we look at the graph of the hip and knee together, then we can see that at that particular phase, the hip is also flexing. When the knee is flexing, the hip is also flexing. If hamstring works, the remaining except then the short head of the biceps, then they will not allow the hip to flex. So it's mainly the short head of the biceps which works as at this phase of the gait cycle. Coming to the extension which is now taking place, again, it's an area where there is a lot of confusion how this extension is taking place. I will describe both the theories which is possible for these extension. Now let us see how the knee moves at this particular phase. When this flexion is taking place, the hip flex and the knee extends. Look at this. The hip is flexing and the knee is extending. It's going down, so it's extending. So the rectus, which works as a hip flexors, has to work eccentrically and allow the knee to extend. So this is where the movements are, the rectus plays a dual role. At proximal end, it has a different role. At a distal end, it has a different role. The second mechanism, which is called a double pendulum effect. Just to make you understand what is double pendulum, we know that this clock has a pendulum. And if we draw this pendulum, it is like this. It has a one hinge at the top, and then there is a slight weight at the bottom. And this is how the pendulum moves from left to right. The double pendulum effect is one higher level mechanical concept where there are two hinges, one at the top and the second hinge is at the center. So now there are two hinges, and to understand the movement of this double pendulum, let's take that this upper portion moves up forward towards the right like this. then what happens to the lower portion? The lower portion also goes forward. So this is what the concept of double pendulum is and how it applies to the knee joint. This is how the knee is moving, and this is because of the double pendulum effect. Coming to the last point, and that is the slow extension of the knee, which is called a deceleration phase. And this is caused by eccentric work of the hamstrings. The hamstrings, they elongate, they stretch, and they stretch to their maximum length, and they slow down this knee extension. So just to summarize how these movement is taking place, a quick revision. Here there is a quadriceps which is working eccentrically. Then quadriceps is working concentrically to produce the knee extension. The soleus is working eccentrically. Then at the neutral position, it's a ground reaction force, capsule, and the soleus. The rapid knee flexion is by the short head of the biceps. This is by the rectus femoris and the double pendulum effect. And the last part is by the eccentric work of the hamstring. I think I end my talk over here because already I'm completing the 30 minutes which is allotted to me. So this lecture is now open for discussion, and we can have questions also.
Dhiren, if I may say so, could you just continue and finish? It's okay, because we have just one case discussion.
Okay, fine. Then I will continue.
Please
Sure.
continue.
Yeah.
Because then we can finish off the whole of the gait cycle in a single session. That would be really nice. You agree, Taral?
Yeah, absolutely. As Dhiren said, it's a symphony, and you cannot break the symphony. Without the hip gait cycle is incomplete.
Okay. Can you see the slide?
Yes, sir.
Yes. Okay. So now we come to the third component, and that's hip movement. It's very easy to understand hip movements because if we look at the hip joint, how it moves. If you look at it starts with the flexion, and then try to understand how the hip joint is moving. There is a extension taking place, and again from that position it's flexing. So if we look at the hip kinematics, there is only a single curve. It starts with the flexion, and then it goes towards the 10 degree of hip extension. And again, in the later part of the gait cycle, the hip is flexing. So let us understand which muscles they control the hip joint movement. So we are trying to understand the first extension which is taking place. And this extension is by two group of muscles. The first is the gluteus maximus, which is purely a hip extensors. And there is a second group of muscles, which is the hamstrings. Hamstrings has a very important role to play at this particular point, and that helps in the hip extension. My dear friend Paolo emphasized that it is at this particular point, if you do any surgery on the hamstrings, then this hip extension will be lost, and that leads to an anterior pelvic tilt, and that causes a more problem with the gait. Coming to the hip extension which is taking place, but now we have crossed the neutral position, and from that hip is extending. So it is at this particular point we are trying to understand that how this extension is taking place. And this extension is not actively by the muscles, but the ground reaction force has now moved behind the hip joint. The black dot is the center of the hip joint, and now ground reaction force is behind the center of the hip joint. The hip extension is taking place. So initially it was by gluteus maximus and the hamstrings. Now it's ground reaction force. The hip is extended fully, and from there it's now flexing like this. So the question is like which muscles they actually work to produce this flexion. And we all know that it's iliopsoas, they work together concentrically to produce this flexion. Again, what we saw in the knee joint, again, we are seeing at the hip joint that at this particular part, the knee is flexing and the hip is extending. And sorry, the hip is also flexing. So how does this movement takes place? Hip flexion and the knee extension. Again, it's a rectus femoris working concentrically at the hip level and working eccentrically at the knee level. And the last part of the slow hip extension which is taking place is by this part, and which is actually the hip flexors, that iliopsoas are working, but hamstrings are working from behind, and they actually slow down this flexion in this part of the gait cycle. So if we summarize the hip movement which is taking place, it's very easy compared to the knee joint. The initial extension which is taking place is by the gluteus maximus and by the hamstrings. The second extension beyond neutral is by the ground reaction force. The flexion which is taking place is by the psoas, iliopsoas, and the rectus. Both are working concentrically. And then the hamstrings, they work eccentrically and they slow down the flexion which is taking place. So there is a slow component of the flexion. So this is in nutshell about how the hip moves. So that is the end of all the three joints: ankle, knee, and the hip movement taking place, and the muscles which are controlling this movement. Why this is important for us? Because any gait deviation, we need to understand that there must be something wrong with these muscles. The first possibility is the muscles are not generating enough force. And the second is muscles are weak because of the strength issue or because of the lever arm issue, and there will be a gait abnormality. So with that, once again, thank you very much to the Masi for allowing me to share these views about normal gait and the control, the muscles which are controlling that. Thank you.
Thank you, sir. It was a wonderful talk. Sir. Thank you.
Can we have some questions?
Yeah, sure, please.
So, Dhiren bhai, it was a wonderful talk, and every time we hear this talk, you know, the concepts about the gait and the forces behind the curves we see, you know, they become more and more clear. And I would say this is, you know, how a clarity of mind can explain basic concepts. I think this talk is very, very important for anybody who's trying to understand gait analysis, you know, either neurological or orthopedic problem. So, you know, I would like, you know, one question which always has come to my mind is that we always study the muscles which move a joint during a gait cycle. You know, a lot of we hear that, you know, Jayanth and Paulo and everybody has been saying that stability in the stance phase and clearance is something which is often underestimated. I realized this when I had weakness in my lower limb muscles, and you know, unless your tibialis posterior and peroneal, they are working together, the soleus will not be able to plantar flex your ankle in the third rocker phase. It's just one of the examples, and I just wanted to emphasize that how stabilizers are as important as movers in a gait cycle. So, you know, any sort of comments on that from Dr. Dhiren and rest of the people who are in the panel, including Paulo, you know, are most welcome. Dhiren, we start with you on that.
Yeah. So what you said is absolutely very right. Like I simplified the things and we just took it only the one plane. So what we discuss or I describe is only the side view or the sagittal plane kinematics. And what you said is like there are other group of muscles, they are working in the other plane also. So yes, you are right. Both tibialis posterior and peronei, they are very important because they are maintaining the ankle and subtalar positioning during the first, second, and third rocker. So they also play an important role, but I have not covered the other plane because this becomes a too much dose. So I really don't want to make it more and more complicated. But you are right. I agree with you fully.
Yeah, sir, like rectus is one of the largest muscle in the anterior thigh, and it's like the basic stabilizer or the which stays into isometric position throughout the gait cycle. So in the sagittal plane, I think that is one of the big example of a big muscle, which many a times is confused that probably must be doing a lot of work in the gait cycle, but it doesn't do anything.
So the other important stabilizer, which really has never been given much importance, are the three stabilizers of the pelvis, the sartorius, the gracilis, and the semitendinosus, all three of which start in the three different parts of the innominate bone, and they insert onto the same point in the tibia. And it is absolutely no coincidence that those three muscles are organized in that way. And you can think of the pelvis as a hanging basket, which is suspended from the floor by those three strings. So if you see any hanging basket, it'll always have three ropes. If you have two ropes, it becomes too unstable. And if you have four ropes, it becomes too stable. It can't move enough. So I think nature is just either through a process of trial and error or intelligent design, I don't know, has somehow arrived upon the exact physical principle that would give you the best symmetry or balance between stability and movement, because you can't have too much constraint and you can't have too much movement, too much instability, because both of which would constrain energy consumption, and a lot of things are there. So our body is really very finely designed. And you can see in patients with spina bifida, which we don't see so often now in polio, all these accessory stabilizers, the iliotibial band, all of those things, they're all accessory stabilizers that become much more important and they become contracted, etc. We don't see that so often in cerebral palsy these days. Dr. Selber.
I'm always so pleased to see Dhiren speaking, because he makes it so simple to understand. I think Dhiren should be elected the messenger for Gait, because we still have a lot of resistance. When you start talking about Gait with residents, I can see them all rolling their eyes a little bit, because Gait has been made over the decades such a taboo talk, and it's actually the opposite. It's fun, it's intelligent, it's precise. And if you are an orthopedic surgeon, most of what you do in life is to actually improve gait in patients. Primarily, if you're working on you think about it, you do the spine so that people can walk better. You do the hips so that people can walk better, and so on. And yet, the basic reason why we do things in orthopedics is always relegated to something. This is too complicated for me, and it's not. I think if we could transmit the message to everyone that Gait you don't memorize, Gait you understand, because once you visualize and you understand all these things, you never forget. So congratulations, Dhiren. As always, it was a great talk.
Thank you, Paolo.
Are there any other comments or questions?
So the other important thing was the concept of the double pendulum, the complex pendulum, which is used to explain the knee extension that happens in terminal swing. So the first aspect that I tend to stress is that knee flexion in swing is an inertial movement. It's a passive movement. Obviously, the short head of biceps has an accessory role, but it's primarily a hip flexion, and the knee flexion is passive. And lack of that passive flexion at the knee because of rectus spasticity is what causes stiff knee gait, which is a very common gait pattern that we see. So, and the hamstring acts as an energy transfer mechanism from the hip to the knee. By working at the transition between hip flexion and the knee from flex to suddenly it extends, that rapid extension that happens in terminal stance. Again, the hamstring has a very important role to play in that. And again, stressing Paula's point, which is why you should not be cutting the hamstrings willy-nilly, because they have an extremely important role to play in all aspects of the gait. So
I think I finally am going to help people to understand that a bit. I just submitted a paper to publication. Let's see if they accept it. But talking about spinal pelvic alignment in the sagittal plane, which is something that we gait surgeons don't know, don't understand in most cases, because most of us only work in the lower limbs, and we work in the lower limbs because we never liked to study the spine. But I endeavored to have a good look at the spine from my perspective, and I found a couple of ways to explain, I think, why we shouldn't do the hamstring. So let's see if this paper is published soon, and hopefully we can change that paradigm of people lengthening hamstrings over and over and over again.
So I just want to quickly present a case that illustrates transverse plane problems. Until now, we have focused the last 2 webinars plus. We've been focusing heavily on the sagittal plane. And I just thought I'd introduce the transverse plane. And this is just an illustrative case, just to show how we look at transverse plane problems. So this is a 12-year-old girl, a GMFCS level 2, community walker. She's had a previous left tendo Achilles lengthening when she was about 6 or 7 years of age. She presented to us with severe intowing gait on the left side. There was increased popliteal angle on physical exam. Both unilateral and bilateral popliteal angles were increased. There was no hip FFD. We found that on prone examination, there was both internal tibial torsion and the neck anteversion angle was increased at the hip. And this is a video of the same child walking. I'm just going to slow that down. So we will just let the video run. Could I just ask Dr. Dhiren to comment on the video? I hope the video is projecting reasonably well on Zoom.
Yeah, it's projecting well. So what I can observe is the right knee is internally placed. And again, on the left side, the tibia is more internally rotated. The component is less at femur level, but it's more at the tibial level. So this is what my interpretation from this visual observation.
And in the sagittal plane,
Okay, so sorry, I just focus on the frontal plane.
Sure,
Can you play it again?
We'll just complete it for completion's sake.
Yeah, there is like crouch gait in both the both the limbs.
Yeah.
The one is more the left. Sorry, the right is more than the left. But there is a crouch gait all throughout the gait cycle.
Yeah. Any comment on the pelvis and trunk and shoulders?
Yes, there is an excessive movement which is taking place at the upper body. So usually our upper body does not move this much, but in her case, the body is moving excessively.
So one can see that the pelvis is retracted, and she also has hemi-body retraction. Her left shoulder is also retracted. And what pelvic retraction does, so pelvic retraction is a compensation for severe intowing. So once you retract the left hemipelvis, that automatically protracts the right hemipelvis. So the internal rotation that you see in the right hip may actually be a compensation. So it's a tertiary level problem. And what the body is doing is, by having a severe problem on one side and a normal side, it's kind of distributing at the pelvis. So it's distributing the rotation so that it becomes, less unevenly matched, is the best way I can put it. So moving on from the video. So
Jayanth,
yes.
Can I just say something very simply?
Please.
So we are always trying to work out mechanisms by which people who don't have a gait lab can appreciate the pelvic rotation. And one of very simple ways to do it is to put two markers on ASIS. Two markers on ASIS. Normally, when we walk from a properly taken side video, you will not be able to see the marker on the other side. So if from a left side shot video, if you are able to see a marker on the right side, and if you take the difference because every video is a plane, 2D plane, right? So if you calculate the distance between the two markers, it gives you an indication of rotation of the hemipelvis. And same thing for the video which is taken from the right side.
Yeah, I think for those who, absolutely. For those who don't have a gait lab, just marking the knee with a circle, putting two bright spots on both ASIs, and also making a line, a vertical line on the heel, or looking at the posterior coronal video, really makes a huge difference to appreciating some of the finer details if one does not have a gait lab. So anyway, so this is the way most gait analysis systems capture the transverse plane. So this is looking at the pelvis in the transverse plane, looking at the knee, the ankle, and the foot. And what most gait analysis systems do is that there is a reference plane, which is the lab axis. So the pelvis is calculated in relation to the lab axis. Then the hip is calculated in relation to the pelvis, and knee in relation to the hip, and foot in relation to the ankle. So each body segment is represented in relation to the more proximal segment. And therefore, one can say that in the transverse plane, problems are additive. So, you start with pelvic rotation, and hip rotation is basically pelvic plus distal femur. Knee rotation is these two plus proximal tibia, etc., all the way down to the foot progression angle. And in some systems, the foot progression angle is again represented in relation to the lab axis, and in some systems, foot progression angle is represented in relation to the tibia. So it's very important for surgeons to know what is the convention that is followed in the particular gait analysis system that you are using. And that's very important when you want to correlate gait findings with clinical exam findings and video findings, because we make a lot of important surgical decisions, whether to do a femoral derotational osteotomy or a tibial derotational osteotomy. or some kind of foot correction surgery, knowing how exactly the particular gait analysis system the company has represented the transverse plane is extremely important. So this is the kinematic graph of the same child. And you can see that there is a significant hemipelvic rotation. So there is severe retraction of the left hemipelvis and a corresponding protraction, because this is basically a single structure. Hip rotation, you can see that it's almost within normal limits. Yeah. So what is happening is the left hip is actually quite severely internally rotated, but the body is compensating for that by adjusting it through left hemipelvic retraction. But then once you come down to the knee and to the ankle level, you can see that the problem, because of internal tibial torsion, the transverse plane problem reoccurs again. So we also see that there is excess dorsiflexion at the ankle, excessive knee and hip flexion, as commented by Dr. Dhiren. There is a single bump at the pelvis, left hemipelvic retraction. Hips are in neutral, surprisingly, but that is just because of the compensation. The knee and feet are in. So in 2014, we did a bilateral hamstring release. This is before Dr. Selva.
Can you go back? Just go back to one. So if you see a knee varus valgus, you see a lot of crazy things happening, and these are confounding factors because of rotation.
Yeah. So you can see that when there is severe rotation, you can see that there is some slight marker placement errors that happen, and these are extremely difficult to control. And the system also has some limits as to how much of malrotation or malalignment that it can reasonably tolerate. And some systems like the Vicon have, so some systems like Vicon have something called a knee alignment device that helps to improve marker placement. But there will always be some amount of marker placement error when you have very severe abnormality in one or more planes. So this girl underwent a left femoral and tibial derotational osteotomy and a bilateral hamstring release. And this is her about 4 years after the surgery. In 5 years, 2019, you can see that she's gained a lot of weight as she went through her pubertal growth spurt. She's walking a lot slower. And you can see that I have slightly over-released her left hamstring. This is the time before we were doing hamstring transfers. We were doing conventional hamstring releases. But you can see that her transverse plane problems are corrected. You can see that the hemipelvic retraction on the left side is also significantly improved, and her foot progression angle is much better. So we will look at her pre-op. So if we look at her post-op gait analysis compared to the pre-op gait analysis, you can see that the amount of hemipelvic retraction that she had has gone down significantly, but now she is moving the pelvis a lot more, because of her weight gain and because of increased energy consumption. And you can see that the hip again is more towards normal, and then the foot progression angle is within ideal limits. In the sagittal plane, I think I have over-released her left hamstring. So you can see that there is a little bit of recavatum on the left side in mid stance, and I have slightly underdone the hamstrings on the right side, which is perhaps absolutely the correct amount of hamstring release. But in practice, these are very difficult to judge. So those are the improvements that have been produced by the surgery. Questions and comments?
So something which you pointed out but didn't speak about was the anterior pelvic tilt. which was excessive. So I want you to comment and follow also your words of wisdom on that anterior pelvic tilt, what causes it and how it can be prevented. Over to you, Jayanth, first to you and then to Paul.
Yeah, I think I was saved a little bit by the fact that I under-released one of the hamstrings. If I had over-released both, then I would have had really severe anterior pelvic tilt. But this girl is now 22 or something, and she's doing quite well. I think she's maybe 19 or 20, an adult, overweight, but still managing to stay at GMFCS level 2 and maintaining her function. But anterior pelvic tilt is a problem because she's overweight, she's weak, doesn't do enough physiotherapy. And in addition to all the problems that I have also created by over-lengthening one of the hamstrings. Dr. Selber.
Before Selber speaks, I just want to ask you one question. When you did the derotation osteotomy of femur, was it distal or proximal?
Distal.
Distal. And did you also correct the knee flexion at that time? Or
Yes, it was. No, I did a hamstring release. So, yeah, it was all done in a single sitting.
Okay. Follow over to you.
So Jay, you know what I think about this. I think it's I've said it over and over again over the years, and Dr. Jim Gage before me. I think we looking at the knee alone it doesn't tell you the whole picture. As you know, I've seen the adults as well over time and since the beginning of my career. So I see them when they're 40, they're 50, they're 70. The other day I derotated a tibia in a 62-year-old woman because she had liver arm dysfunction because of that. Yeah, I'm sure that you have moved on from simply lengthening hamstrings. We all know that lengthening hamstrings extend the knee. We all know that, and our predecessors knew that as well. Lengthening hamstrings sometimes hyperextends the knee. The problem is the pelvis, and nobody was designed to walk with a pelvis so grossly anteriorly tilted. So you cannot imagine that this person is going to be healthy when they're in their 30s or 40s with anterior pelvic tilt that much. So when we start looking into the sagittal spinal pelvic alignment parameters, you see that this is directly correlated with quality of life in adults. And there's a lot of papers that talk about that. So anyway, I think we have to use this case, and lots of people have these cases. They don't feel bad about it. Just to teach the younger generation to say we need to do better than this. We got her better, the knee is better, the rotation is better, but the pelvis is really, really worse. So and this is not okay. And this is not okay when they age. And I think there are better ways these days to do that. And I know, Jay, that you do them. So yeah, I'll continue to emphasize that to everybody that I can.
I think this girl missed your famous talk in Mumbai by a few weeks, I think, because it was in 2014. And I think you came to Mumbai in 2014, if I'm not mistaken. So,
all right.
Anyway.
Jen, sir, can I add?
Yes.
Yeah, sir. So just a little observation, which I have seen over past few years, that kids who walk with such a dynamic adduction at the knee, most probably their gracilis are more tight as compared to the semitian semimembranosus. And if I had to do this, I would probably shorten the femur while doing the derotation and just lengthen the gracilis and not touch the semitian semimembranosus. And I most often follow this now in all the hemiplegics. So I don't lengthen all the three and I just focus on the gracilis, because hemis, the knee doesn't show the changes so bad and quick, but sometimes, but this dynamic adduction, I think that is one of the reason. And particularly in the graph in the knee varus valgus, which Taral sir also pointed out, it was quite more obvious. So when in the graph also it shows a lot of such thing, I think the gracilis is probably the more of a culprit rather than the other two.
So you're looking at this, the hip adduction?
The lower one, sir, the knee valgus.
This one.
Yes.
Yeah, but you can see that in post-op, we've got our marker placement better. So I mean, I did release a gracilis. So it.
Yeah. So you could have left the semi-T and semi-membranous. Just the gracilis. So probably the tilt would have been better.
Remember, there's a paper from Scott Delp that shows how sensitive semimembranosus is to lengthening. I would strongly suggest that we leave semimembranosus alone. And again, we should not try to get the knees extended through the hamstrings. The only thing that I think it's safe is to do the semi-T transfer. Anything more than that, if you're thinking that you need to do more hamstrings to get the knees straighter, then I think you're wrong. You need to stop there and use the other surgical doses that we have. You know, if the kid is young, you can do anterior hemiepiphysiodesis or guided growth. If the kid is over that age, then you can use supracondylar extension osteotomies. Hopefully one day we'll see most of these kids not getting hamstring surgeries, so that when they're adults, they don't suffer so much because of the pelvic tube.
Jayanth, how old was the child when you operated her?
She was 12 years old. 12 years old.
So, and when did you do the implant removal?
A couple of years later.
Yeah. So one thing what we have seen again in children where we have used plates for distal femoral osteotomies is inadvertently there is valgus distal to the plate. You know, this has been described. The mechanism of this, you know, people have spoken about, but you know, this is very evident in children where you've done one-sided surgery somehow. I really don't know what is the reason. And in a couple of these patients, we have had to do a valgus correction surgery later on at the time of plate removal. You know, so if you see her, the latest video, and it shows that there is more valgus in the left knee as compared to the right. And this could be one of the reasons.
You think it's because of some kind of overgrowth phenomenon, or because we don't dial in any valgus varus when we do a derotation?
Yeah. This is post plate, so it's normally it starts a year following the plating. So this is whatever cases I've seen of knee valgus following a distal femoral plate for any reason. You know, what happens is after a year it starts, it maximizes at 2 years and then stabilizes. So and it never corrects spontaneously. So if you pick it up well enough before the child's growth is over, at the time of implant removal, you can do a guided growth to control that valgus. But you know, now with at this stage, you know, either you have to, you know, accept it, or because the correction is another surgery.
Yes.
And we really don't know what is the effect of that valgus on a gait pattern or the joint forces. Any other comments? Dhiren bhai, last you know, comments from you on this case which Jayanth has presented. And
like say what Paulo said, I think we really need to focus more and more on the pelvic tilt. So that is one eye-opening thing of Paulo. So, but what Jayanth said is like this was before his introduction of semi-T transfer very strongly at Mumbai. So But I think that, yes, what he said, that instead of relying on the hamstrings, it is better to go for other sort of surgical dose. So let's see, because like results of that also will give us some wisdom over a period of time. At this stage, we are saying that the hamstring surgery is bad, but we don't know the other side. So let's have a few years experience with that, and probably we will be learning something from that also.
Great. So, but I hope, I just wanted to present how we view the transverse plane and how gait analysis systems capture the transverse plane and how the mathematical calculations are performed by the systems. That's important to understand that it is an additive thing, whereas the sagittal plane is not additive. It happens concurrently. The transverse plane is an additive thing. So when
I just wanted to ask you one question. So Chasnal had done a study of transverse plane abnormalities, and in a study, we sort of correlated that whatever happens between the knee and ankle, the tibial torsion, and the tibial torsion measured clinically or on CT scan or on gait lab, it all goes well hand in hand. But in femur, nothing correlates. Whatever is the amount of internal external rotation, which you measure clinically, whatever is the amount of anteversion, which you measure on CT scan, and the rotation of the hip on a gait analysis, that doesn't seem to correlate, especially in a pathological gait. So, we would like to know something from Jayanth, you and Paolo both on this aspect, and then Chasnal can add a few results of a study.
So I almost correlate this to a scoliosis. So if you have a high thoracic scoliosis or a lumbar scoliosis, it will cause imbalance. Whereas if you have got a problem in the middle and you have got a few segments above and below, the body will try to compensate. So the minute you get to tibial torsion, there isn't enough limb left below the tibial torsion for the body to do any sort of compensation. And you don't have a joint that has movement in the transverse plane. So the body cannot do it. So whatever is the abnormality will be reflected in the foot progression angle. Whereas if you have a femoral anteversion, in torsion or out torsion, the body has a lot of options. So it has the pelvis above by which it can compensate. And it also depends on the available rotation. So even if you have increased femoral anteversion, if you have external rotation at the hip available, so the body will use the available external rotation to compensate for the increased femoral anteversion. So there was a very good study gait study from Brazil that showed that the midpoint of the total arc of hip rotation measured clinically, the midpoint of rotation of the entire hip, whatever movement arc was available, that correlated very well with clinical foot progression angle. So if you have a lot of internal rotation and no external rotation, then obviously you will walk with an in-toeing gait, if you have increased anteversion. But if you have a lot of internal and external rotation available, even if you have increased femoral anteversion, you still have external rotation in the hip by which you can compensate for it, and you will still walk with a neutral foot progression angle. I hope that's clear. You need an illustration to show that actually. But that's the evidence from the literature, and I think that's what Chasnal's study found as well. So
the other thing that's very important is to ensure with all that you can the marker placement, because the system tells you where the coronal plane of the thigh is, and if you get it wrong, then the system is going to give you a wrong information. So that graph, that plot that Jay was showing, the varus valgus moment, the varus valgus position in kinematics is crucial. When those lines are offset from the standard deviation, you can almost bet that the establishment of the coronal plane of the thigh was wrong. Of course, you will see children that have true valgus and true varus, and you need to be sure of that. But I think it's important that before the data leaves the gait lab, the personnel in the gait lab has to double, triple check that data. You know, is femoral torsion matching what we're seeing in kinematics? And if it's not, we need to be able to understand at this point in time, with all this technology, why is it not? And is it not because the patient has a triplegic dystonia and this dystonia is confounding everything? Is it because the marker placement is telling us that the coronal plane is in a different position?
Yeah, I think the static trial is very important, that all the markers are in one line. And in a meeting some days back with Dr. Harris, he did point out us that when we turned the child, the markers at the knee level, the CAD was not in the place, and how the graphs were totally wrong because of that. So I think, yes, we focus more on the graphs, but the biomechanist in the lab should focus more on the static trials before making the child walk, because otherwise the whole thing is going to give some results which are never going to match with our static examination. So yeah, Dr. Selva, that's a wonderful comment from me. Thank you.
Sir, can I ask one question?
Yeah,
Yeah, please.
So we have a lot of talk about the pelvic retraction in type 3 and type 4 hemi. We do a lot of rotation correction here also we are seeing. So anything above than bony correction we can correct in hemiplegic, specifically type 3 and type 4? Retraction, pelvic retraction. Hello?
So what Jaideep is asking is, yeah, pelvic retraction is important anomaly in a hemiplegic child. So can anything be done to correct that?
There's quite a few papers written about that. I must say I've given up trying to predict that, because even despite the papers written, I sometimes see, or more often I see, that the pelvic retraction is only partially corrected. I don't know the answer to that question. I think we derotate the femur, we derotate the tibia, but a lot of them still keep that pelvis retracted. I remember back at ACD, Dr. Ivan and my mentors used to say that there are three reasons for the pelvic retraction in hemiplegics: neglect of that side, the transverse malalignment, and weakness. They used to think that that the hemiplegic side didn't have enough power to push the pelvis forward, so the pelvis was always before. And this is people observing even way before us in gait analysis. And the matter of neglect is well discussed in the field of neurology. And in simple terms, it's almost like the brain forgets that there is that side, and the brain is not taking good care of that side. Sometimes it get if you have a hemiplegic, which is a type 1, or a type 2, where only the calf is tight and everything else seems to be okay. When you have excessive plantar flexion knee extension coupling because of the equinus, that pushes the pelvis backwards on that side. And when you correct the equinus, the pelvis comes back because they're not very involved up there. But when you have a hemiplegic type 3 or 4 and dystonia is always confounding to the patient. And then I think it's a bit harder to get that pelvis in the right position. And I really don't know what to do about it.
So one question, Dr. Selva. So when we derotate these femurs in a hemiplegic, and if the pelvis is probably retracted, does it uncover the femoral head, and what problem would it cause eventually?
Yeah, and Eric Roots, who now works in Melbourne, and Kerr, they have a paper that was published in Clinical Orthopedics and Related Research. The cover of that journal is a pelvic osteotomy that I did, where I had to cover the whole acetabulum, because yes, you can cause hip displacement. You think the femoral head is in the socket, but now the socket, which has compensated itself over the years for that rotation, is completely off-centric. So that's why I also gave up on that, and I give it to the PAO doctors. I've never learned how to do PAOs, new lessons to old dogs, but I give these cases to the hip surgeons, and very often we do the femoral osteotomy, and they go there and match the acetabulum to what we think the femur should be at. So it's working on both sides of the equation at the same time. And a PAO is so much better than, if you see this clinical orthopedic related research, I think it's from, I can't remember when they published that, but you see that I put a shelf all around the acetabulum, and it looks beautiful, and it gains this front cover of this journal, but I had to detach the abductors from the pelvis, and that's not very good for them because they always have weakness there. So a PAO is a much more physiological osteotomy for them, I think. And I must confess, in hemiplegics, I stopped trying to do the socket quite a while ago, and I started sending them all in Melbourne to Mr. Jit Balakumar, who is our guru for PAOs and the likes.
So you have to unmute, Jayanth.
I think Taral, do you want to close the session?
Yeah, so I'm sure there are more questions and a lot of curiosities now generated from this session. So Jasnal, we would end this session, but before that, Jasnal can announce the next session dates, and what is the agenda for the next session.
So we invite the participants from the group for new case discussion for the next session. And this session is held every second Sunday of the month. So it's going to be 8th May. And I'll certainly post the details in the group, but most probably next sessions will be 2 case discussions, just like we had last time. So thank you everyone for joining us today for this wonderful webinar. And we had a great set of participants in the Zoom live meeting. And thank you, Dr. Selber, for being a wonderful guest today at this hour on a weekend particularly. So we are very thankful to you. And thanks a lot.
Thank you. Thank you for the privilege.
Thank you, everyone. Bye-bye.
Thank you. Bye-bye.